So this morning we're going to think together about how can systems engineering, or what systems engineering needs to understand to help primary care. And I'd like to start by answering that question, and the way I would answer it would be with these three things, which are the takeaways for this morning. The first is to understand what drives motivation for primary care physicians and their staff. And the second is burnout, to recognize the pervasiveness and the destructiveness of burnout in primary care. And then thirdly is to look at efficiency and to understand that efficiency is a driver of quality. In fact, I believe if we put our focus on efficiency, many good things will follow, including quality, satisfaction, and cost containment. So our agenda this morning will be first some framing thoughts that I'd like to share with you around burnout, and then we'll spend much of our time giving you the results of a study that we did for the American Board of Internal Medicine called In Search of Joy in Practice. And this will be at a high level that I'll talk about it. I'm pleased to say that the study will be published on May 20th at 5 p.m. Not really looking forward to that, but I very much am and would refer you to that. And then I'd like to share with you some of my own thoughts about the implications of this for the research agenda going forward for primary care, focusing on what John first called the basic science of primary care. And then I'd like to share some efficiency data that Health Partners in Minneapolis has started to accumulate as part of that basic science. And then talk about some thoughts I've had about matching the work to the worker in primary care. So first, burnout. This is a study from Mayo Clinic, Tate Schoenfeld, published in the fall in Archives. And what he found was that nearly 1 out of every 2 U.S. physicians is exhibiting some sign of burnout, and that burnout is especially high among general internists and family physicians. And the authors conclude that if nearly 1 out of every 2 U.S. physicians is suffering burnout, then the problem has to be rooted in the environment, in the delivery model itself, as opposed to being a consequence of weakness on the part of a few susceptible individuals. So I'd like to turn our attention to the study that I had referred to, and first to highlight and acknowledge my co-investigators and the American Board of Internal Medicine Foundation, which funded that study. And what we did was we looked at this central question. In light of the dismal situation in which primary care finds itself, with trainees choosing any other specialty aside from our specialty, with primary care physicians leaving their specialty at 4 times the rate of our other specialty colleagues, in light of that dismal situation, at the very time when we need more primary care physicians rather than fewer, are there places where primary care physicians and their staff are thriving, where the work of primary care is doable and enjoyable as a life's vocation? So that was our central question for this study. And we identified 23 high-functioning practices where we felt patients were getting excellent care and where it was a good place to work as a physician or staff. And one or another of each of the investigators spent a day at each of these practices, shadowing the physicians and the nurses as they did their work, and then interviewing leaders at the organization. Our lens was focused at the most granular level of workflow and task distribution. Who did what in the practice? We also looked very intently at the infrastructure, at the physical and at the technological infrastructure, to identify how did those features either help or hinder the team as they were doing their work. And so the challenges that we identified, and the challenges that I think are important for industrial engineers to understand, are the following. The first was chaotic visits with overfull agendas. Second is inadequate support to meet the patient demand for care. The third is vast amount of time spent documenting the care and complying with administrative and regulatory requirements. And the fourth is EHR implementations that push more work to the physician, work that might previously have been done by a transcriptionist, by a receptionist, by a medical records clerk, by a pharmacist, has now become the work of the physician. And the fifth is teams that function poorly and complicate the care rather than simplify the care. So those are the basic challenges that we identified that we think generally affect primary care physicians across the country. And so for each of these challenges, we highlight innovations that address those challenges. And again, I'll just very briefly skim over those, and if you're interested, read more in the paper. And we actually will publish at the same time much more in-depth study about each of the sites we visited on the ABIM Foundation website. So the first challenge, chaotic visits with overfull agendas. And the innovations here are all around planning ahead. With pre-visit planning, some of the practices making a phone call to the patient a day or two before for agenda setting. With pre-appointment lab, so that at the time of the visit, the physician and the patient can engage in shared medical decision-making around the results, rather than having the lab done after the appointment and then having all the results reporting work to follow. And I found that for every 4 hours of clinic, there's generally about 2 hours of post-appointment results reporting, and we can eliminate most of that by re-engineering the way the work is done. And then the other is taking a systematic approach to prescription management. We estimate that we can save about 30 minutes of physician time and about 60 minutes of nursing time per physician by taking a streamlined, synchronized, bundled approach to prescriptions. And by that I mean renewing all the chronic illness prescriptions once a year, in our case at the annual comprehensive care visit, and renewing them for the full year, or in Iowa we can do 15 months, as you can in many states. And what that does is it eliminates the need to keep repeating the same work over and over again throughout the year. Well, you might say, what difference does it make? 30 minutes of physician time, 60 minutes of nursing time. So let's convert that into primary care capacity. And if we say that by re-engineering that prescription work so there's less wasted time, we could see one more patient a day across all primary care physicians, that would be additional capacity for 80 million primary care visits a year. Second challenge was inadequate support to meet the patient demand for care. And the innovations here are all around sharing the care. And the most robust models that we found had 2 or even 3 nurses or medical assistants per physician. This allows a much more robust rooming protocol. It also allows stronger between-visit care with health coaching, care coordination, and panel management to be done within the team. This is Dr. David Eitram and his 2 nurses. He's at a Mayo Clinic satellite in northern Wisconsin. And he and his nurses developed what they call the new model of nursing, moving from a 1-to-1 to a 2-to-1 model in their core team. And in doing so, they moved from a physician-centric model of task distribution and responsibility to a team-based model. So his nurses take complete ownership of the immunizations and the cancer screening in their practice. They do and document the diabetic foot exam. They have some hypertension-only visits. They do lifestyle counseling. And when I was up there and I asked the nurses, well, what's different in your new model? They said that even though they're able to see 25% more patients, they have capacity for a much larger panel now. They feel less harried at the end of each day. In addition, they are justifiably proud of the care that they can now give their patients. Citing the example of a patient with diabetes falls off track with their management, they can proactively reach out to that person, bring them back into the practice, and help to prevent the devastating complications of diabetes. So the third challenge is vast amount of time spent documenting the care. So I think many physicians very realistically think that they spend more time documenting the care than delivering the care. And we can look at that as a potential source of waste to be eliminated. This is a physician in Alaska who wrote to me, I used to be a doctor, now I'm a typist. I'd like you to look at this picture. It's a famous painting from 1891 entitled The Doctor. What do you see?
No computer.
No computer.
Cup of tea.
I'm sorry?
Cup of tea.
A cup of tea. All right, so time, maybe. What I see is a physician giving his patient undivided attention. He is focused on that patient. This is the doctor in 2013. What I see here is what's been termed continuous partial attention, that we live in an age of continuous partial attention. And I think we give our patients continuous partial attention, or what I've recently seen identified as inattentional blindness, the things we miss because we are not paying attention. And I watched, as I was the fly on the wall in many of these practices, patients sending signals to their physician, excellent physicians, but they were focused on the screen and they missed those signals. And I'm sure that happens to me when I'm focused this way. So the innovations here, scribing, or what I prefer to call collaborative documentation, and assistant order entry. So this is Dr. Peter Anderson at Newport News Family Practice, and in his practice, the nurse stays with the physician from the beginning to the end of the appointment. And then when my husband was the one who visited this practice, he's also an internist. And when he came home, he was so excited, and he said, "This is what we've always hoped for. This is what I went to medical school for." So in Dr. Anderson's practice, there are 3 nurses per physician. And in the first component of the visit, the nurse may take 8 to 12 minutes. And during that time, she does a lot of work. She does the vitals and the medication reconciliation. She also begins to develop the HPI. She helps the patient set their agenda. She gathers all the relevant information for that appointment. And then she goes through a guided review of symptoms with the patient. Then the physician joins them for the collaborative part of the visit. And during that time, the physician then delves much deeper into the history. The physician does the exam. He verbalizes the findings. He also verbalizes the plan to the patient. And while he's doing that, his nurse is recording the visit and also operationalizing the labs, the meds, the next appointment. Then the nurse stays with the patient after the physician component of the visit, and she reviews this with the patient. She does health coaching, she does education, she prints and gives out the after visit summary, and she pre-schedules then the next appointment. Meanwhile, the physician has moved over to the next patient who the nurse has prepared in a similar way. This is Dr. Kevin Hopkins, and he and his medical assistant went to visit Dr. Anderson and came back to the Cleveland Clinic. He had to present a business model before he could do this at the Cleveland Clinic. And they were able to identify that if he saw 2 more patients a day, he would cover the cost of that additional medical assistant. And he says here, the medical assistants are more fully engaged in primary care than they ever have been, and they enjoy their work. They have increased knowledge about medical care in general and about their individual patients in particular. And I will tell you that we do this in our own practice, and the nurses are not only better informed during the care, during the visit, but also for all the between visit calls because they were in the room at the time. So the 4th challenge is computerized technology that pushes more work to the clinician. This is a physician in Des Moines who said to me, "The task list is unbearable. I spend an hour and a half clearing out my task list before leaving and another hour and a half after the kids go to bed." And I would tell you, I also find this a near universal experience in primary care. If you want to think about a joy killer, you look right here. So the innovations here include verbal messaging and inbox management. This is Fairview Clinic in Minneapolis, a large integrated delivery system. They've embarked on a system-wide care model redesign. One element of that is empowering the nurses and the medical assistants to filter the inbox. So they pull off the task list, any task that they're empowered and trained to do. And only those very few inbox messages that really need the physician level of engagement are passed on to the physician. And they report that they've been able to reduce what they call the backpack of work, the work the physician takes home every night, from an average of 90 minutes to an average of just a few minutes per night. I also wanted to point out another thing here about the physical space. You can see the medical assistant at her station has line of sight to all of the exam rooms for which she's responsible. And that's an efficiency. She knows what's going on. She can keep the clinic flow going. Many of our study sites understandably began their electronic journey thinking that asynchronous communication was the way to go. Only paradoxically to learn a few years later that actually face-to-face verbal messaging in many circumstances is actually more effective and more efficient. And it precludes the need for having these e-messages circling round and round the office in this thicket of email communication. The innovation here is a semicircular desk. And this is at the Mass General, the ambulatory practice of the future. And what it does is a very simple thing, but it allows the patient and the physician to face each other so they can communicate face to face. And then when they need to, they can turn and include the monitor and make it a three-way conversation with the electronic information. A variation on that at Iora Health, semicircular desk, and you can see this comfortable relationship between the patient and the physician. And the physician is giving that undivided, full attention to the patient. At Iora, they also have health coaches who stay with the patient from beginning to end. And here you can see that he is recording much of the visit during this section. The fifth challenge is teams that function poorly and complicate rather than simplify the work. And the innovations here are all around creating forums for communication through co-location, through daily huddles, through weekly team meetings, and by doing workflow analysis through techniques such as workflow mapping. So here's a flow station at North Shore Physician Group. Physician and medical assistant work side by side throughout the day. They can answer questions, do messages, get a lot of work done very efficiently in this setup. At South Central Foundation in Alaska, the care team is made up of a provider, a nurse, a medical assistant, and a clerk. And so that's what they call an integrated care team. And 3 integrated care teams are seated in this large workspace. And they are surrounded by an integrated care team, an extended care team of a pharmacist, a nutritionist, and a social worker. So if the physician has a question, he can ask the pharmacist right on the spot. If there's a patient who needs social services, a warm handoff can be made right that same day. This is a similar bullpen sort of setup at the ambulatory practice of the future in Boston. And you can see the space for co-location, but also I wanted to point out the line of sight. The exam rooms surround the perimeter of this site, so there's good line of sight. This is a team meeting at the University of Utah at Redstone. The idea here is that every person, every worker, every member of the team comes to work every day, not only to do today's work, but to make tomorrow's work better by analysis, by communication. So those are the highlights of what we learned as we went through these site visits. And now I'd like to shift our focus to thinking together about what are some of the research questions that come out of this work and the thoughts that we've been developing over the last few days. And I think the basic thing is we need a basic science of primary care. There is so much we just don't know. Just the tip of the iceberg. We don't know how we're spending our time. We don't know how much time our physicians, nurses, medical assistants, each spending on documentation, on billing, on phone calls, on messaging, on paperwork, on prescriptions. I think we need to define the current state before we can make the future state. Looking at all those activities, what % of those activities require a physician's level of training? Do we need 11 years of high school training to do much of the work that physicians are doing? So as I've thought about it, I think much of our research has been focused at these higher levels. At the international level, we've got Commonwealth comparisons across primary care, across countries. In the U.S. healthcare system, we've got regional variations, the Dartmouth Atlas work. At the organizational level, we have work on ACOs now. At an individual practice level, we're thinking about medical home. But really, the unexplored territory is at the level of individual worker, the number of clicks and steps and tasks that those workers are doing. And I think there's such a potential if we look at the core work to make improvements. And looking at that work, I'd like to focus on matching the work to the worker, finding ways to avoid waste. I think we have a tremendous amount of waste. In fact, I think we waste about 3/4 of primary care physicians' day currently. We have the potential to reduce burnout and to preserve our primary care workforce. So with that, I'd like to turn to some of the beginnings of this basic science of primary care that I have picked up from other practices. So this is Health Partners in Minneapolis, and they've identified that simply putting a printer in every room saves 20 minutes a day. That doesn't surprise me in the least. I have watched physicians run back and forth, down hallways, around the corner, get the printer, down hallway, run back to give it to the patient for a task they shouldn't even be doing in the first place, let alone have to go on that long journey. Flow stations, they found that those saved them 30 minutes a day. Large monitor saves 30 minutes a day. Pretty simple, but a big deal. So just those simple things have saved an hour of physician time a day. And I'd like to end by sharing with you some thoughts that I have developed over the last couple of years, building off a graph that Al Mully told me about that he had in mind. Al Mully's at Dartmouth. And it's about matching on the y-axis the complexity of work, and on the x-axis the training. And recognizing that at some point, there's a line of optimization. And that if we're above that line, if the worker is doing work that's more complex than their training, well, that's unsafe. And if we're at a place below that line, where the worker is overtrained for the task, well, that's inefficient or waste. So let's just, and then there's this sweet spot where the worker and the work are well matched. So what I did is I looked at much of the work that we saw physicians doing and tried to graph it out as to where it belonged. And at the top, we've got what I think is what motivates physicians. I think this is really the essence of our work. It's accurate diagnosis. It's making an appropriate therapeutic plan for the patient. It's managing complex, often competing chronic illnesses. It's relationship building, trust and relationship. And then it's empowering patients in shared decision making. I think that's the high value work. That's a good match between the work and the worker. But let's look at where physicians are spending most of their time. Inbox management, medication reconciliation, prescription renewals, data entry, data gathering, prior authorizations, and signing for everything, signing even for hearing aid batteries. If you look at that, in my view, that's inefficient and that's waste. And there's a lot of it in primary care. This is Dr. David Moen, and he had been at Fairview at the time of our visit. He was the director of care model innovation. And he told me, we have developed a new mental model. Pull the doctor out of the infrastructure, typing EHR work, and get them back to being present to the patient. So much of what we noticed at our study sites that was innovative involved moving these dots. Instead of assigning those things to the physician, distribute those tasks more appropriately to the team. And moving all of that work to workers who are completely capable of doing that, and for whom that can be value add for them. And that allows the physician to add more value to the patient and to the healthcare system. So back to those takeaways. What do I think industrial engineers need to understand about primary care, and really what I think primary care physicians need to understand? First of all, what motivates us? What drives physicians? Well, I think it is medical decision-making and relationship building. And if we're not doing that, we need to look at every other activity as potential waste. Burnout. We need to realize how extremely pervasive burnout is, and that we will not have a strong U.S. healthcare system in the future if we do not have a strong primary care physician workforce. And that efficiency is our ticket. If we focus on efficiency, we will find our way to the rest of the triple aim. The triple aim being better care, better for individuals, for population, and at a lower cost. And I'd like to end with some words from Sir William Osler, who I think was very forward-thinking, even in 1893, when he said, "Medical care must be provided with utmost efficiency. To do less is a disservice to those we treat, and an injustice to those we might have treated." So I'll stop there and thank you.